Adi, thank you for this talk about for the organization committee. I will talk about the vertebral augmentation, which is the second step of the osteoporotic fractures. Osteoporotic vertebral fractures is the main problem of all of the world because it's the incidence of osteoporotic vertebral fractures is rising along with the elderly population's longer life expectancy. In United States data, 1.5 million osteoporotic fractures they diagnose in annually. Half of them is the vertebral compression fractures, and 115,000 patients needs hospitalization. Is the big problem. Where osteoporotic vertebral fractures is the most common vertebral compression fractures. It's often undiagnosed. 12% of patients is diagnosed. It's progressive, and it causes mortality and morbidity because the patients are the elderly patients and they have some systemic disease. So the mortality and morbidity is higher, this disease. And also the vertebral body height loss, deformity, sometimes the kyphotic deformity. And the first and main problem is the pain these patients. Thoracolumbar junction is the most common localization. But I want to say if we see the compression fractures T5 and above, we should be the suspected it can be a osteoporotic fractures. What is the diagnosis? What can we do? Usually we use the radiographic examinations. Plain radiographs, we can see the high loss of the vertebral corpus. You can see the kyphosis and sometimes fracture line and intravertebral cleft we can see. MRI is the most important imaging of this patient, this disease, especially the STIR fat suppression MRI sequence. We can see the bone edema is the very diagnostic issues. Bone scintigraphy or computerized tomography, we can use the which patient who cannot undergo the MRI. What is the treatment of the osteoporotic fractures? Dr. Kim tell about the first step of the osteoporotic vertebral fractures. First step is of course, the bed rest, brace, and medical treatment. Conservative treatment. What is the second step? Second step is the vertebral augmentation. I will talk about it. And the third step is maybe some patient open surgery. What is the vertebral augmentation? Vertebral augmentation is the percutaneous injection of the polymerizing agent into the fractured vertebral body. If we are using a balloon, it's called we called it a kyphoplasty. If we don't use the balloon, it's the vertebroplasty. What's the indication? I told these patients the main problem is the pain. The first and main problem is the pain. Vertebral augmentation, we expect the pain relief, osteoporotic fractures, refractory medical therapy for 3 months. Improve the quality of life, of course. And we should be a mechanical stabilization of the spine. And if the patients have a kyphotic deformity, we can prevent it with vertebral augmentation. It also helps us to reduction of the complication, because the patient is elderly patient and has some systemic problem. So the patients we reduce the complications rates. How does the vertebral augmentation reduce the pain? We don't we know the mechanism of the which vertebral augmentation reduces the pain, but there is the three possible mechanisms have been proposed. Mechanical stabilization of the fractured bone, preventing in the painful individual fracture fragments. Thermal destruction of the nerve endings due to a high temperature reached during polymerizing of the spine. Heating nociceptor in the bone tissue, heat procedure by the polymerizing process as the acrylic hardens. And also chemical destruction of the nerve endings due to chemical composition of the cement. How can we make the decision which patient needs the operation or which patient go the conservative treatment? There is a classification by the German neurological surgeons, German orthopedic and trauma surgeons conclude that they are divide the osteoporotic fractures, the five type, type 1 to type 5. Type 1, there is no bone destruction. Type 2, just the end plate, one end plate destruction and fracture. Type 3, the incomplete burst fractures, and they divide the type 4 three portion. One of them is the complete burst fractures. Other one is the vertebral plana is the very compressed corpus, vertebral corpus. Other one is the puncture fractures, the white vertebral corpus, and the type 5 is the anterior and posterior column destruction, and they call it the kyphotic. These patients have maybe kyphotic deformation, and they conclude a scoring system because of the what we decide what can we decide the operation, and they add some other tools of the scoring system. And finally, if the patients has a score 0 to 5, they recommend the non-surgical management. They recommend the conservative treatment. If the patients is take the 6 point, it's the surgeon's preference or the depends of the patient's situations. If the patient score higher than the 6, its surgical management is indicated. And also, they conclude that type 1 and type 2 osteoporotic fractures classification of these fractures, type 1 and type 2 may be treated with conservatively. Other type of 3 and 4 and 5 is treated with surgical treatment. They conclude that vertebroplasty is consist of injection PMMA into intersects of the fractures, vertebral body, or direct into fractures lines to relieve pain and stabilize the fracture. Kyphoplasty is attempts to correct deformity secondary to vertebral compression fractures by inflating a balloon to reduce the fracture. The resulting void is filled with PMMI. what is the best? What is the better, vertebroplasty or kyphoplasty? There is no, there is a lot of studies. Pain relief and functionality is the same. Both methods are successful and accurate. But wedge angle restoration or vertebral body high kyphoplasty is more effective improvement in the than the vertebroplasty. There is some advantages of the vertebroplasty, less control over PMMI delivery, more extravasation we can see. Typically lower volume injections because there is no empty area of the vertebral corpus. No effort to reduce the fracture. If is there any complications, contraindications for vertebral augmentation, kyphoplasty or vertebroplasty? If responsive or healed osteoporotic fractures, there is a contraindication. Asymptomatic stable fractures, it's contraindication. Also, allergy to PMMI, there's contraindication. Patient do not treat it with prophylactic for osteopenic or osteoporotic patients. Prophylactic vertebral augmentation is not recommended. And also other things. There is a relative contraindications for vertebral augmentation. Significant compromise of the spinal canal, back pain or known fracture for greater than 1 year, vertebral body collapse 19% or greater, we called it the vertebral plana, bone fragment extension into epidural spaces, inability of patients to lie prone position during of the surgery. We talk about the benefits of the vertebral augmentation, long-term pain relief, fracture stabilization, early mobilization, decrease risk of comorbidity, improve mental health, and if we need biopsy is to rule out the secondary causes. Procedure preparation. I will talk about a little technique. Select approach. We can use the transpedicular, parapedicular, or unilateral or bilateral pedicular approach. Both approach can be used, the vertebroplasty and kyphoplasty. We select appropriate needles and visualize the bone landmarks and advance needle to target area. We can use the multidirectional single or biplanar fluoro or CT. We need a true AP image. What is the true AP image? We have to see, we should see the end plate, parallel end plates, upper and lower end plates. Pedicle in the middle, we should see the fluoro in the middle of the upper half of the vertebral body in the pedicles, and also equidistance of the spinous process. And also we need the true lateral image, the parallel end plates, and superimpose the pedicles. There is a red line or the entrancing the pedicle. The red line is the middle border of the pedicle. We have to check it. Don't cross the mid line of the pedicle. And we start the usual transpedicular percutaneous transpedicular application. We are using all attempt of these stamps. We are using the fluoro, or if you have a CT, don't always remain the red line. Don't cross the red line. Don't disrupt the medial wall of the pedicle. we can see the bilateral transpedicular approach, and then cement injection. We will always done in lateral position, but check the AP position. Do not over injection because of the extravasation, avoiding the extravasation. 2-3 cc's for thoracic space. 4-7 cc's is the lumbar space is enough. Always use viscose cement because avoiding the extravasation of the cement. When cement hits the posterior wall, vertebroplasty can be stopped. Cement in disc most likely non-significant. Reports of the some fat emboli maybe, and may allow the cement set based on the injection time. May spin needle the break the potential cement spike on the soft tissue. There is some potential complication for vertebral augmentation. Overall of then less than 1%. Some minor complications, asymptomatic cement leakage, temporary neurologic deficit, clinical complication related to comorbidity is not reduced. Some permanent complications, maybe symptomatic cement extravasation, temporary neurologic deficit, pulmonary emboli, and other type of the complications. If the foraminal extravasation, patient say us if the not general anesthesia, local anesthesia, the radical pain, radical damage. Sometimes disc space extravasation. Avoid it, stop the injection of the cement. Don't allow the too much cement injection. I have some cases, example cases. 80 years old female, intractable pain for 6 weeks. There we can see the two level grade class 1 type 2 fracture, and you can see the fractures. We put the cement for vertebroplasty with vertebroplasty. It's okay. The other one is the 3 years old female patient. The first appointment is the back pain and the walking difficulty. We advise the patients just a decompression surgery. You can see the MRI. There is a spinal stenosis L4 to 5 level. She confused it. I don't want to do any surgery. And 1.5 weeks after, the pain worsened after a fall. You can see the changes of the vertebra. It's like a crash. And multi-level vertebroplasty we performed, and she's okay. Before the surgery, she's bedriding, no walking, just riding, bedriding. There is a different type of the vertebral augmentation system. It's called, example of the one of them is the Osteofix. There is a titanium cages, titanium meshes, and other type of system you can use. Which one is the what is the summary of the vertebral augmentation of the osteoporotic fractures? It's safe and effective in subgroup of patients with acute osteoporotic vertebral fractures. It's maybe treated 5. If the conservative treatment not success, the 5 and 6 weeks in. Pain relief post-op is immediately faster and sustained 1 year minimum significantly greater compared with the conservative treatment. Proper patient selection yields most optimal outcomes. Thank you.
Thank you so much, Dr. Ender Ofluoğlu, for this great presentation.